And on behalf of my colleagues, Mike Reed and Arista Janji, and the whole Decolonizing Global Health Working Group, thank you so much for joining us today. Just as a little background, I think many of you have joined us previously, but for those who have not, we started this series over a year ago as the COVID pandemic and waves of anti-Black violence were really turning more attention to how our own institution of global health practice can reinforce and deepen inequity and coloniality. And we wanted to create a space for global health researchers, educators, and practitioners to come together and have frank and sometimes hard conversations about our field. We really wanted to make a space where we can ask questions and think about questions together about how the field of global health needs to change if we are going to build the equitable, radical, anti-colonial communities that so many of us say are really at the heart of the work that we do. And so we hope that these sessions can offer a time for reflection about what our governance structures look like, our financing, our education and research practices, and how those can either reinforce or alleviate inequity. And we want to also think about new ways of doing work and think about ways in which institutions like our UC research institutions can contribute to new ways of working that really address the impacts of colonization throughout the global health field. So with that in mind, I am really thrilled to introduce a leading thinker and person kind of taking the lead on asking and answering some of these questions, Dr. Tammam Aloudat. Dr. Aloudat is a Syrian physician and humanitarian worker with over 20 years of experience, currently serving as the managing director of the Global Health Center at the Graduate Institute of International and Development Studies in Geneva, Humanitarian Health at PLOS Global Public Health. Dr. Aloudat previously worked at the International Federation of Red Cross and Red Crescent Societies and MSF on conflicts, natural disasters, forced displacement, and more. So we are so pleased to welcome you to UCSF today. And I'm going to give the floor over to Dr. Aloudat for the first half of the session, and then we will open it up for Q&A. I've had the pleasure of speaking with him before, and I know there will be lots of questions coming out for discussion. So with that, I will turn it over to you, Dr. Aloudat, and we look forward to hearing your thoughts.
Thank you. Thank you very much for having me, and thank you for the opportunity to speak to you. By the way, if you feel the urge turn on your other audience are horrified or facial reactions are excellent here. I apologize. I am sitting effectively on the side of the road. I have miscalculated badly how much time it takes to drive from one place to the other, as I don't drive. But I mean, global health is a field of contradictions, and it is one that's interesting in its contradictions. So the fact that I sit beside you today and I'm wearing a suit, which is by no means the stuff I wear every day, is because I'm going to have a meeting with some of the people who are in this diplomatic field in Geneva who work on global health. And I was told in no uncertain terms that if I show in anything less than a suit, I'd be severely punished. I even have tied my tie a priori because I can't make it the right length in time. But this is part of global health. Another part is standing beside a patient in a place like Niger, where I worked for a while. in Iraq, in Syria, my country of origin, or so on, whereby you are exposed to not only a level of suffering that are difficult to imagine if you are trained as a physician, at least in a different context, in a context of a highly developed context or high income country, but also with the need to find ways to bring down medicine or healthcare services to a level that it can be affordable in places like that. You work long enough in this line of work and you find that you are adjusting the quality of care of what you do to the available resources rather than to the imposed needs on the populations. The protocols become interesting but not obligatory, because there is no way of applying gold standard of medical care or of any health service. We've worked before on issues like the moral injury that people suffer after having worked in our field for a while, the inability to provide care that they know needs to be provided. Now, this is not unusual, right? In at least the past couple of 100 years, since nation states have become something of a standard practice, there hasn't been a situation whereby there is an equality in income or an equality in expenditure or inequality of services across states. Actually, you could argue that as far as we know historically, well, actually, no, not as far as we know, but for a long time in history, the differentiation in reception of wealth and of care that is made available by wealth have been incongruous, at least across populations within same nations or territories and across them. Now, why is that significant? There are a few points of significance, I think, that are important to mention. One of them is that we have a rhetoric that is different now. We talk about humans as humans of equal value, equal worth, equal being, and we practice otherwise. And there's no need to go far or further than the fact that Pfizer just yesterday asked for an authorization for a fourth booster, for a fourth dose, a second booster, while the healthcare workers and populations at high risk remain unvaccinated in the vast majority of sub-Saharan Africa, for example. What Dr. Tedros, of all people, WHO are not known to be radical rebels, but Dr. Tedros in no uncertain terms called that a vaccine apartheid. And apartheid is not a word you utter lightly, just like genocide, crimes against humanity, or the similar. Those are reserved rightly in most cases for situations where the injustice that is inflicted is so horrifying that there are no other words. And there's a care that is taken, rightly or wrongly sometimes, in not using expressions like those frivolously. So what does that have to do with us? An argument that you would hear repeatedly is that we are exposed to situations of severe injustice, and what we are doing is actually providing the best possible care for people who are suffering those injustices under circumstances of severe strain. Now, that is true, and that is true for almost every single person I've known that works in global health. And that is actually brilliant, because the work of global health, and this is the first caveat I will put forward, is the work of global health is effective, and it has saved many people's lives, and it has succeeded. Now, it has succeeded. One of the earlier successes before global health was even called that is the eradication of smallpox. The others is the massive reduction in childhood illnesses as a result of the expanded program for immunizations, for example. Measles has reduced almost entirely across the sub-Saharan Africa in the first 15 years of this millennium. There are situations that have been resolved. The argument I'm going to make today is that those aren't reasons to celebrate, that having some successes in a sea of failure that ends up, rather than changing the core of the injustice, enforcing a status quo that is unjust by design and by intention, is not good enough. And that we as people who practice global health, research it and work on it, are brought into unwittingly or by necessity or by the absence of alternative into a situation where we are made to serve the exact cause that we have set up to oppose. And I'm assuming that, like most of the people I know who came into this field, you have come to it because you do deplore the injustice that people suffer and want to do something about it. So let me try to break it down. Global health has many definitions, and there are like literature reviews about the definitions of global health. And you would be justified in thinking, okay, this is ludicrous. Why don't we just go and do something rather than sit and, speculate how many angels can dance on a, tip of a needle. But that is important because the current agreed, the best one I could find, says that global health is a set of actors who work to improve health and achieve health equity across international borders. Now notice, there are a couple of things. There are actors that are intentionally assigned the label of global health by by self-proclamation. If you call yourself the international global health something or the other, then you're a global health actor. But they are also, if you look at some of the studies on global health actors, they are overwhelmingly based in the global north. They are overwhelmingly designed, led, and implement from the global north and overwhelmingly towards the global south. They largely have leadership that is that comes from and is based in the global north. Now, that might not be entirely wrong, if you think of it, if you're inclined to think in terms of efficiency. You'd think, if the outcome is good, if it's doing the best it can do, then why would I bother where the headquarters is? No one argues that Coca-Cola should be based in the global south and that Pfizer should have their headquarters somewhere. But that is not applicable in a simple sense. That global health only can argue this argument if it assumes itself to be the application, the widest possible application of biomedicine, that is the treatment of diseases with technologies such as medicines or surgery or diagnostics at the widest scale. And the first argument I am going to make is healthcare is not biomedicine. Biomedicine merely is a fraction of healthcare. So that being the case, biomedicine is also healthcare is also the social aspects, how people perceive themselves, how do they see their health or the deterioration of health. Healthcare is also a societal one. Addresses illness and sickness as they are perceived by society. What do they lead to in terms of acceptance, exclusion, stigma, and cost of living? Global health and healthcare is also a political economy. Who benefits from it? And where does the benefit go? What does it cost at the cost of what? What do people have to go through to gain healthcare? It is one thing, and this is not about the global south here. Talking to you sitting in the United States, this is not a problem that is absent from the scene of healthcare in the United States. There are massive differences in the healthcare available, and hence life expectancy according to the geography, class, gender, and ethnicity in the United States, as it exists largely across the world. So global health is definitely not the actors that call themselves global health. So what is it? And how can we address it in a way that acknowledges its engagement in power politics beyond the formal programs of global health? So I'm suggesting a definition here. Global health is any policy or action that is systematically, positively or negatively affects the health of people beyond the territory or country where that policy is designed or implemented. What am I trying to do here? What I am trying to do is to say that global health is not only about global health programs. It's not about health aid, which is worth about $20 billion a year officially, which is, as you will know, a negligible fraction of almost any other trade. Let's not, we could talk about weapons trade now that weapons are being used on a daily basis in Ukraine, but not even that. If you look back at COVID, $2.6 trillion, that's 2.66 thousand billion dollars. It took me a bit to count all the dots, the zeros, was increased on the wealth of the 100 richest people in the world. That is worth the whole of global health about 1,000 times over. And that is speculation. That is pure speculation. One of the biggest beneficiaries is Elon Musk, as you will know, is the richest person in the world. He's a brilliant, mature, incredibly smart guy. When he became the richest guy in the world, he sent a sculpture of the number 2 to Jeff Bezos, who became number 2, to tease him, and it was pretty expensive. But that's beside the point. Refused to provide some money for hunger. Not that I care that Elon Musk refused or would give money. I don't think that's a solution for anything. I'm just saying that this is where we sit as a discipline, at the bottom of what costs and consumes money. So who are the other actors then? The other actors are many. The other actors are the industry, the ones who take public money, who take from the NIH compounds that are developed by taxpayer money, develop them, put them under intellectual property rights, and charge the same taxpayers again for them to be used by the public. Actors of global health are governments, not only who are acting as donors or recipients of global health money, but who act in ways that, obviously the Russian government is now a global health actor because of the massive crisis that they have caused in Ukraine that will have health implications. But let's not fall under, the vague impressions of only things as obvious as the war in Ukraine is an act that negatively affects people's health. Most of the European countries that have a much better human rights record than Russia still supply, and Canada and the US, by the way, still supply the United Arab Emirates and Saudi Arabia, which are at the same time used to justify, the progress of the West and how regrettably backwards others are supplied with weapons so they can bomb Yemenis today, 6 or 7 years after the conflict started. The allowing companies to consume public money and to charge for it is action on global health. The gag rule that every Republican government implants to prevent money of the US government to be spent on anything related to termination of pregnancy in poor countries is an action on global health, even though its sole intention is to get votes in the Bible Belt. So global health is more complicated, and it's not only a positive act, it is a negative act in many cases. Facebook, the biggest source of information for people about their health, is a global health actor, whether Mr. Zuckerberg likes it or not. So where does that leave us? There is a formal global health business whereby actors that carry, the badge carrying actors sit in rooms in Geneva and New York and Washington, DC, And I'm not saying that accidentally. In the study I mentioned from Hoffman 2015 that examined about 200 global health actors, found that the vast majority of headquarters are in Geneva and Washington, D.C. and New York. Most of the money, most of the decisions get decided there. So, and those in a study, in a report from Global Health 50/50, which is an organization concerned with the gender parity and gender equality in global health, they have found that 70, 80, 90, 70% of all the leadership, highest level of leadership of global health actors are white men from Europe and North America. They have found that 80% are from Europe and North America. So those are the non-men, non-white portion. And they found that 90%, another 10% in addition, are people who aren't from North America or white, but who have studied in institutions that are based in North America and Europe. That hasn't changed despite a massive change in leadership in the past 2 years. There's plenty of lip service that gets given to diversity and inclusion, which I would argue is an activity that is as dubious as they come. Sarah Ahmed, who is an Australian researcher who worked on diversity and inclusion, among other things, in universities in Australia and the UK, within a but a significantly substantive book called On Being Included, says this is where equity regimes are used to serve inequity regimes. By having a diversity and inclusion officer who has no authority and hardly any space to talk to the leadership, who are supposedly very concerned about the topic, a checkbox is checked and the topic and a justification is made and hardly anything changes. We do end up hiring people of color after we make sure that they will act as white as they can. And by that, I'm not being facetious. I actually was yesterday talking to a person in an NGO where one of the leaders who hopes to get elected for an international president in that NGO, this is not a humanitarian NGO, but similar stories go. That person comes from the global south, is a woman of color, and her sole concern, her platform for election is about combating reverse racism, because that's what's going to get her elected by the membership in Europe and North America. And, just so we're clear, there's no such thing as reverse racism, but we can argue that if you want. So we have a much more diverse global health field with actors that do acknowledge or do not acknowledge their participation or engagement or hence responsibility in this field. Okay, so fine. What's the problem with that? The problem is that this field has nearly failed to achieve any of the promises, formal or informal, that is made in the past 30 years. Let's walk back. You remember Alma-Ata, right? Alma-Ata, 1978, health for all by 2000. Obviously, health wasn't delivered for all by 2000. There were achievements and there were losses. There were a negligence that is criminal for HIV patients in sub-Saharan Africa that cost several tens of millions of lives until medicines were available abundantly, and they still aren't available enough. And now we're doing the exact same thing with tuberculosis that has started breaking out way too badly, and where medicines that are new, non-injectable, not toxic, are still not available. Then there was the 3x5, if anyone remembers that. 3 million patients with HIV on highly active antiretrovirals by 2005. Obviously, that hasn't happened. There were the Millennium Development Goals where we were going to halve poverty and save every child from early mortality. That hasn't happened. What do we do after every failure? We double down. So if you were going to, get a contractor and repair your house, you really needed something repaired. And every time they came, they messed it up. And they charged you the money and they went and spent that money. would your reaction normally be to call the same guy and ask them to repair the damage that they have caused? Of course not, because even if you don't believe neoliberal economic theories, not everybody is homo economicus, but we are rational. We don't do the same, we don't get slapped on the face 70 times without any reaction. But in this case, we have allowed an oligarchy of leadership in global health to control the lives and deaths of millions of people. This is problematic in multiple ways that are specific to global health. And well, I talked about several failures. I'm not going to remind you of the failure of COVID again, and that will continue to be the case. But COVID is fascinating in one respect that those other failures do not carry, is that COVID continues the rhythm of structural racism, oppression of others, exclusion and deprivation of health, even when it affects us negatively. It's one thing to ignore people's health because you don't care. It's another thing to enact policies systematically over 2 years in a manner on a problem that has been predictable and continue to do so despite that negatively impacting your own health, your own economy. But that's the failure, that's the nature of the beast. We have accepted a system that will consistently and systematically fail to deliver even a simile of its promised achievements. COVAX is a sub-organization of Gavi, the Global Alliance for Vaccines and Immunizations, that has absorbed almost all the money available for vaccine equity in the world since the beginning of the pandemic. And that was a particular choice, and that was a particular choice that was pushed by Bill Gates, none else. The gentleman who has fought all the 90s to protect intellectual property so people wouldn't gain money by plagiarizing his software, and who continues to do that now to protect pharmaceutical companies from their medicines being produced generically, even in a crisis of this sort. So COVAX fails. Obviously, there was supposed to be a 20% of the population of every country member of COVAX vaccinated long before now. That hasn't happened. The answer, give us another $25 billion so we can vaccinate more. How many people got fired? None. At least no one is that significant. This is symptomatic of a bigger problem. All those are symptomatic of what we will again call the coloniality of global health. And I will here make an argument of global health not being, a bunch of failed businessmen who just don't know how to do their job. Because that would be letting them off the hook way too easily. That would be giving up our responsibility as people who have and will continue to be engaged in global health in the service of other people and justice, health justice, from taking action. Here I will go back and follow on the footsteps of Walter Rodney, who talked about development and how Europe underdeveloped Africa. And he talked about the possibility of development being reduced and eliminated by the fact that we are told that development has occurred in some countries. And we are told that those who are developing, which he vehemently denies is a useful word, because many of the poorer countries aren't developing, they are actually going on the other direction. So he calls them underdeveloped countries, are supposed to follow in the footsteps and with the aid of those countries to succeed. So if we are to address this coloniality, which is not only, obviously it isn't a coloniality of invading armies, but it is the continuation of the mentality that has accepted the previous colonial powers and the fact that they have their resources today because of 500 years of colonization as deserving of their resources and as benevolent forces that will continue to give something to the poorer countries as charity, mind you, not as reparations. And we will accept in exchange to give them dominion over people's health. So that is problematic. That is absolutely problematic because the goal is not to provide equal health to all people across the globe. Even the definition of the right to health is the highest attainable level of health, attainable per country, not attainable per science and technology. So what do we end up with when we accept this system? We end up, I would argue, with a class of people who are either sick or at high risk of sickness, or are consumed by sickness in their families, loved ones, societies, or countries, that they have been deprived of a potentiality in the future. Here, I will reverse, if I may, the idea of social determinants of health, of political or technological or so on determinants of health, and talk about health as a determinant of all those issues. Health is a determinant of social progress, both individually and socially. Health is determinant of economic progress, of wealth. Health is a determinant of education, and hence the circle goes on and goes on. And by being complicit with a system that puts profit and puts national interest in a hyper-nationalist manner above the possibility of solidarity, we are not only condemning people who are sick to die, we are enforcing an impossibility of any better future. And that isn't done exclusively by global health actors, but global health actors have, in the name of scientific, a biomedical rigor, refused to engage in the politics of their discipline. We have for the longest time allowed for a small oligarchy to control how resources are spent, how are they justified, who gets to live and who gets to die. And I insist on the who gets to live and who gets to die, because we don't only decide to save people by deciding who gets services, we decide who doesn't get them. And we have to confront that choice. We don't get a free pass on those decisions. So we have that. And we have a situation that has failed. That contractor has messed up our, prepare way too many times. The conversation about the need to create an alternative global health that is led by people in their needs requires a different way of thinking. This doesn't require only a redistribution of resources, it requires a rethinking of what health is. And here, as a physician, it took me 2 decades to start clicking with this, because I am trained in Western medicine that tells you that, you take stuff once, they are out of clinical trials and approved by the FDA. That's medicine today. You memorize them. Now we have computers, you don't even have to memorize them. And, you get more skilled at recognizing the subtleties of diagnostics. We're technicians now. We aren't physicians. I will finish here. In the Middle East, in my country, in Syria, in Arabic, a physician in the old days, I mean before the 60s and 70s, used to be called Hakim, not doctor. And Hakim means a wise person. And that was because physicians were engaged in this. So they were some of the few, with the very few educated people in their communities. And hence they were arbiters, they were judges, they officiated marriages, they arbitrated disputes, they helped, delineate lands, they, went on the heads of to celebrate and to mourn. And that word isn't being used because it's not scientific and rigorous enough and isn't earned anymore. And this will only be returning once we have, I would say, the ability to go out from the exploitation that across the globe affects that class of people I described. I would call them subaltern because I want to plagiarize the work of the Subaltern Studies Group in India as part of the post-colonial studies. The subalterns is useful because it doesn't describe a class in a single society. It describes all people who are excluded from making decisions on their own life. And here, people who are excluded from making decisions on their own health. This means a mother in Niger, where I described, that has no way of dealing with the malnutrition of her child, is equally a subaltern to a woman, a Black woman in the US, who doesn't get painkillers equally to a white woman when she is in labor. This is the massive number of differences that we attribute to a biomedical guidance and that are socially inflicted and are inflicted by with one thing. This is not a claim that there are people who are racists in the global health discipline. This would have been easy. This is saying that all of us are conditioned and made to work into a system that is fundamentally racist, that inherits the intellectual frameworks of coloniality, of colonialism. And mind you, colonialism wasn't seen as a bad thing in its day. It was civilizing people. The only difference today is that we're healing people instead of civilizing them. We're healing them without asking them and against their will in some cases. But we are giving ourselves a carte blanche because we are healing people, just like they did when they were civilizing them. In both cases, that, at least in part, covers profit motives and national or nationalist interest. And the change of that is only when biomedicine, I think, when biomedicine is put in its place alongside social and political and economic factors that affect people's health, and all the choices of them are given back. It's not about consulting people. It's not about asking for feedback. It's about ceding any sort of power to people whose health is being served. I know it's difficult. I know we all know better than most people, but that difficult exercise is exactly what happened in decolonizing countries from invading armies, and is hopefully what's going to happen in combating the coloniality of global health in the future. Thank you very much, and I appreciate the time. Thanks.
Thank you, Dr. Aloudat. That was very, so I have so many questions and so many strands of, things that I would love to continue discussing, and I'm sure many of our participants do as well. So I'm going to hand it over to Arista to kick off the discussion, and just a reminder to everybody to put your questions in the chat or raise your hand to ask directly. So Arista, do you want to take us away with Q&A?
Yes, thank you, Naomi, and thank you, Dr. Aloudat, for this very insightful and unique.
Please call me Tammam.
Tammam, okay.
Thank you.
And I apologize for having my video off due to some technical issues, but I'll just be facilitating the Q&A portion of this session. So as Naomi mentioned, if you would like to raise your hand and put any questions in the chat, we will kind of facilitate those and direct them to Tammam. I think to start off with, one question that we've asked a lot of our speakers to weigh in on is the positionality of our institution. We, the Institute for Global Health Sciences and the University of California, San Francisco, are based in the global north in the United States, in one of the most expensive cities in the country. And so, how, as an institution that probably perpetuates many of the systems and, power dynamics that you talked about, how can we change our way of doing things and thinking so that we advance that new vision of global health that you talked about?
Thank you, Arista. Okay, so in my experience, this is answered in one of two ways. screw all science and, institutions and so on in the global north. This needs to be shifted into the global south. And I do understand the urge behind this argument. However, and obviously the argument of the status quo doesn't fly, at least when you're having this conversation. So let's gauge the possibilities. I don't think a disengagement by people who are historically part of communities that exploited or colonized or so on is justifiable or desirable. Because if those of us who are white or have come from countries that have colonial histories decided, okay, it's not my place to talk now. You're one of the people who are actually considerate and sensitive about this issue. You disengage, disappear into the shadows, and who's left? The raging, racists, the people who are unable to see any of the argument as valid, the people who embody the problem in the system. It polarizes the system even more and creates a state that is unsolvable. So my first argument in individual terms is that everybody has a possibility to engage and an obligation to engage that is commensurate to the privilege you have. Let me give you an example. In the Extinction Rebellion in London, they wrote a book called This Is Not a Drill, and it ranged the book articles about everything they've done, from cooking to protesters to how Maldives is by the president of the Maldives, how the country is going under the sea. One of them is about protests, about closing bridges. And they were talking, what? The rich middle class kids, white kids, were in the face of the police, and their aim was to get arrested. They wanted to get, and they knew Daddy will come and take them out. It's not going to mean the end of their careers or the end of their education or so on. So they did. But rather than do just that, they formed shields that protected people who would lose their careers if they were arrested. People of color, people who have disabilities who cannot be brutalized by the police, and so on. That, I'm not saying go get arrested. I'm saying there has been a conscientious choice to increase the risk per privilege. If you're going, just like the argument of equity and equality, it's not the exact equality of risk. It is us conscientiously shielding each other and protecting each other. People with tenure have the ability to speak more than people without tenure. People with seniority can speak more than people without seniority, and so on and so on. An institution needs to be pushed. Institutions are sticky stuff that like to stay where they are, especially if they are privileged. Yeah, most universities pay highly, and they need to be able to provide continuity. It's rare that people do that, do something that, but that isn't desirable. That is, what is desirable is to open up the space for others to speak, to be present, is to go out from the mold of this is the singular way science can be done and medicine can be done, and we will only do it within a framework of a neoliberal capitalism that cannot even imagine opposing pharmaceutical companies, into opening the discussion. I'm not saying, I talked about political economy, and I know that, Marxist terms terrify people in the US because of the dogma that has been attached to it for decades. But, I'm not saying go and raise a red flag over your over your institution. All I'm saying is allow those voices to compete, allow voices from the global south to not to come as informants, not to come to tell you about their lived experience, but to come and teach on the same leg, and to research and to write and to be accepted and to be published on the same leg that gets offered to white people. And if you think I'm being ridiculous, I would invite you to read a couple of books about COVID. One of them is by Slavoj Žižek, who is a famous communist philosopher. And the other is by Bernard-Henri Lévy, who is another philosopher. Both of them have fuck all idea about what medicine is and what COVID is. Žižek wrote 2 books and Henri Lévy wrote 1. And they are the biggest pile of BS you will ever read. And that's not to discredit Zizek. He had good ideas in his days. But he quotes, like his references are Wikipedia. I read both his books twice, and I couldn't get anything out of it. Guess what? If Zizek or Levy weren't white guys with the protection of their institutions, they wouldn't have been published. If they sent them with a name like mine, those wouldn't have been published, much less if they were with an African name or a, So opening up possibilities for others is what needs to be done and what should be done absolutely and without.
I think we've lost our speaker. Let's give him a minute to reconnect. And while we're waiting for that, if folks want to put some questions in the chat, we'll probably have time for a few more. Well, maybe while we wait, I'm curious if anyone had any reactions or